Good afternoon to all of you who are with us today afternoon. We have one a new webinar, European Down Syndrome Association, now nearly 2 years and a half, are doing very nice, very interesting webinars. Today, our topic is the dual diagnosis of Down syndrome and autism. And we are so pleased that our speaker today is Noemi Spinazzi. Today, our webinar is translated again in several languages. We have a Turkish, German, French, Czech, Croatian, Ukraine, and Italian. We would like just to make a few tips and tricks for you before we give the words to Miss Noemi. Fulia, you could continue with Slidler. Like I said, we have several languages, and you could find your own language if you go and look down on the bars where there are interpretations mentioned and find the language on which you would like to listen our webinar. Just few notification. The webinar and this meeting is being recorded and is going live broadcast on the Facebook. Like you see, we have a few languages, and it's a recording also not only in English but as well in other languages. We will have this recording on our media, our social media as well. The webinar is not for diagnosis or and the treatment, and content of the webinars reflects the view only of the authors and speakers, and ETSA cannot be held responsible for any use which may be made of the information obtained therein. If you want to watch our previous webinars, please go to our ETSA channel on YouTube and subscribe it, and you will hear previous webinars and also this one. This one will be there in at least 10 days, and you could listen as well. Yeah. Okay. If you have any question, like you see, you could just hear us, but for the possibility to ask us something, please use again on the button down on your screen is asking questions and comments. And on that button, if you click, and you will put in the question for us, and we will answer you or during the presentation or after presentation. Thanks a lot. Follow us on our social media on Facebook, Instagram, Twitter, and also on the YouTube channel. I would like to give words now to our speaker. Noemi, please start with your presentation. Thank you, and have a really nice webinar because the topic is very, very interesting.
Thank you so much. My name is Noemi Spinazzi. Can you see my screen so that you only see this one slide at a time? Can someone let me know? I'm gonna get started. My name is Noemi Spinazzi, and I am the medical director of a Down syndrome clinic in California in the Bay Area in Oakland. I don't have any financial interests or relationships to disclose, and today I will talk to you about the dual diagnosis of Down syndrome and autism. So, of course, you all know what is Down syndrome. It's a genetic condition. One has Down syndrome if they have an extra copy of the 21st chromosome. It's either diagnosed before birth or at birth based on facial and body features, and it's diagnosed with a blood test. So in a way, it's a quote unquote easy diagnosis because a blood test will tell you yes or no, is there Down syndrome. What is autism? Autism is a developmental difference. Unlike Down syndrome, where we know what causes Down syndrome, the extra copy of the 21st chromosome, we don't yet know exactly what causes autism. We know that there is a combination of genetic and environmental factors, but there's still a lot of research to do in understanding the causes of autism. It is characterized by three main features: difficulties with communication, especially social communication, the use of any type of language for the purpose of having a back and forth interaction with another individual. But not just communication, also understanding, difficulties with understanding and sustaining social interactions. The second core feature of autism is a restrictive and repetitive pattern of interests and behaviors. And then the third main feature is sensory difficulties, including sensory integration difficulties. And I'll talk more about what that means during the presentation. While Down syndrome is often diagnosed even before birth or right at birth, autism is typically diagnosed around 2 to 4 years old, although sometimes later. And there is no blood test or X-ray or MRI that diagnoses autism. It is diagnosed through a complete developmental evaluation that requires an expert person performing this evaluation. Can Down syndrome and autism happen together? Absolutely. And we used to think that it was rare, and now we know that in fact it's actually pretty common for people with Down syndrome to also have autism. And it is very important to recognize when someone with Down syndrome also has autism, because it's really important to understand it for the purpose of treatment. How common is it really? The best estimates that I have seen show that about 16% of individuals with Down syndrome also have autism, and that's the full autism spectrum from very mild cases to more severe cases. About 8% of those with Down syndrome will have a more significant presentation of autism also. It appears to be more common in males. It may be more likely with some medical conditions associated with Down syndrome, specifically infantile spasms. Those children who have a history of infantile spasms, a type of seizure diagnosed in young kids with Down syndrome between 6 months and 2 years, are 20 times more likely to be diagnosed with autism later on. When you test a child with Down syndrome and autism with IQ testing, so intelligence testing, they will come out with lower scores, but it's not clear whether that's because truly their cognition is more impacted, or because these tests are not made for someone with both diagnoses. And so it is actually quite hard to fully understand how a child with both diagnoses is doing in terms of their cognition. And not uncommonly, there can be a family history of autism too, in a sibling, in a parent, in a close family member, and if not autism, of other neurodevelopmental conditions. I told you that having a history of infantile spasms increases one's chance of having autism by quite a bit. I was the author of a study that also looked at other medical conditions that appear to occur more frequently in those with both Down syndrome and autism as compared with those with Down syndrome alone. And it does look like a lot of gastrointestinal issues, constipation, reflux, feeding difficulties that are already common in people with Down syndrome are even more common in those who have both diagnoses. And then interestingly, we found that there was a greater chance of having been diagnosed with scoliosis if you had both diagnoses. Scoliosis is a curvature of the spine, and our research group is wondering whether that is actually because maybe many kids with both Down syndrome and autism have much lower muscle tone and end up developing scoliosis. But there's a lot more work to be done to understand what medical conditions are more closely associated with both diagnoses, and that is work that we are definitely doing in our research organizations. I want to spend a bit of time in this presentation talking about the presentation of children with both diagnoses. What does autism look like in a person with Down syndrome? We did a study surveying parents of children with Down syndrome and autism, and we asked them, at what age did you start wondering whether there was something more than Down syndrome going on? At what age did you develop some concerns about your child that they might be different from other children with Down syndrome? And parents told us that on average it was around 3 to 3.5 years old. And unfortunately, what we found from this work is that it often took between 3.5 and 4.5 years to finally receive a diagnosis. And I hope that your experience has been different if you are listening in as a parent of someone who is dually diagnosed. But it is unfortunately something that I see in my clinical practice, that parents bring up their concerns maybe to their children's doctor or teachers, and many don't know much about Down syndrome and autism and might dismiss the parents' concerns. And it's not until they come to see a development specialist or a Down syndrome specialist like me that they obtain a diagnosis. So that's why we talk about how it presents. And so I'll talk about different things that you might see in a person who has both Down syndrome and autism. The first one is what are called stereotypic behaviors. These are behaviors that are repetitive, that look similar every time, and that don't appear to have a clear purpose. It can be hand flapping, it can be repetitive movements with hands, it can be twirling strings or other things, bringing them close to one's eyes or mouth. It can be rocking, just like I'm doing right now, or spinning. Um, and what's really important to know is that these repetitive behaviors can be seen in kids who only have Down syndrome also. But when someone also has both Down syndrome and autism, they tend to do this more. They tend to have more types of these stereotypic behaviors, and it's harder to distract them away from it. So I might see that one of my patients who only has Down syndrome does a little bit of repetitive behavior, but then when I invite them to play, they stop doing what they're doing and they'd rather play with me. A person who has Down syndrome and autism might really need to continue to do these stereotypic behaviors to stay focused, to stay calm and regulated, and might persist rather than starting to play with me or have a social interaction with me. Another thing that we might see are some differences in the style of play. Most young kids with Down syndrome, up until they are at least 2, they might really like those toys that light up, what we call cause and effect toys. I touch a button and music appears or lights appear. And then they bring a lot of toys to their mouths. But as they grow older, kids who only have Down syndrome will begin to do some pretend play. They might pretend to give a baby doll some food. They might pretend to make cars drive around. They might pretend to eat toy food. A child who also has autism, on the other hand, may be more focused on lining up toys or sorting them by shape or color, or they might really continue to prefer those cause and effect toys for a long time. They might continue to put toys in their mouth for a very long time when they're 5, 6, 7. They might be more focused on a part of a toy than the whole toy as a whole. An example is I have baby dolls and toys in my office, and a kid with Down syndrome and autism might be really focused on the eyes or the nose of a Mickey Mouse doll and maybe touch it or put the nose in their mouths and suck on it, as opposed to playing with the Mickey Mouse doll and pretend to give them food or put the Mickey Mouse doll to sleep. So we ask a lot about play in our visits. Another thing that parents tell me is that kids with Down syndrome and autism might prefer to play alone instead of trying to join play with other kids. We see some challenges with social skills in a lot of kids with Down syndrome, right? The communication challenges of young kids with Down syndrome can make it hard to interact with other children. Um, and there's a big interest, right, in other kids and wanting to join play with other kids. Um, Kids with both Down syndrome and autism, um, they can still look more social than kids with autism alone. And often when I walk in a room, they give me a big smile and they might look at me in the eyes. And then it can feel harder to sustain the social interaction. It takes me a lot more effort to engage them in play as opposed to them veering off to going to play on their own or play or continuing to do their own thing instead of wanting to engage with me. One thing that a lot of toddlers and older kids with Down syndrome alone will do is that they'll do have what's called showing behavior. They might show me a toy, not because they need help, because it's cool and they want to share that cool thing with me. Or they might try to call attention to them, like, look at this, look at me. And we see a lot less of that in kids who have both Down syndrome and autism. It's a little harder to imitate, and it feels like a little bit less of a back and forth. An example, I saw a girl just last night with a dual diagnosis. And when I walked in, she gave me this big smile and she was obviously so excited for me to be there. And then she really loved the ball that I brought in. And her game was really just to throw it. And I tried to sit with her and tried to do some back and forth throwing of the ball and really showed her how to do it. And really, the more I pressed, the more she would just go and try to do her own thing with the door stopper of the door. So again, some of this difficulty with back and forth and imitation and joint play. Some kids are really more withdrawn and really just seem disinterested in engaging. Autism is a spectrum, and so some kids will have slight milder symptoms and others will have more significant symptoms. The challenge I see very much is a difficulty with communication that is greater than what we see in kids with Down syndrome alone. And we know that it's hard to learn to talk when we have Down syndrome, right? And it's even harder to learn to communicate when we have both Down syndrome and autism. One thing that I always ask about is gestures. So I'm a big proponent of using sign language in young kids with Down syndrome to help them communicate. We use American Sign Language in the United States. And so a child who's been exposed to American Sign Language and is 3, 4, and still doesn't use simple signs like more or all done, um, uh, or may do them, might copy them with a prompt, but doesn't use them on their own, or might copy a word. They might be perfectly able to copy the word milk or to say milk, but when they want milk, instead of saying milk, they stand in front of the milk and cry. Why aren't you using the word that you know how to say for the purpose of communication and social communication? That is something that I see often in someone who has both Down syndrome and autism. Oftentimes, they're not using a pointing finger to point to what they want, and especially to things that are cool, like a plane in the sky or a puppy in the street. The use of pointing to share an interest or to share a want or desire is something that we definitely see in children with Down syndrome, even if they're not yet talking, but that might be missing for a long time in children who have both Down syndrome and autism. Another thing that parents of kids with just Down syndrome tell me is, yeah, they're not speaking very much, but they understand so much. On the other hand, parents of kids who have both diagnoses tell me that their children continue to struggle with following directions, even directions that are fairly simple and familiar. So, a difficulty with both receptive language understanding as well as expressive language speaking. And when we are speaking, it might be what's called echolalia, repeating the last word that was heard or repeating little scripts of phrases that they have memorized. as opposed to spontaneous language. And often it might be out of context. So, one big thing I teach parents as well as providers from a very early age is make sure that there's lots of exposure to gestures and gestural language, because it really helps us later in life understand if there are additional diagnoses to be considered. We talked about sensory difficulties being a core feature of autism, but what does that even mean? So we have 8 senses. We have our vision, our smell, our taste, our hearing, our touch. Also, proprioception, the feeling of our body in space. Vestibular, our sense of balance. And interoception, which is the feeling of gas bubbles when we have to fart, or the feeling of hunger that we feel in our body. All these 8 senses, the brain has to make sense of. It has to process them, and then it has to modulate them. It has to decide, I'm going to make this input bigger because I have to pay attention to it, and I'm going to tune out maybe a distracting thing that is happening in the background so that I can focus on what I need to focus on. And kids with autism have a really hard time with that sensory integration and modulation, making it so that they might be very sensitive to loud noises, to bright lights, to specific textures of clothes or food, um, to things like haircuts and the dentist, and things that have to do with touching things. It might look like throwing a lot of objects or refusing to engage in certain touch type activities. It might look like big meltdowns in crowded places and family gatherings. And sometimes it looks like big, big tantrums without a clear cause for them. And then eye contact can be different in people with both Down syndrome and autism. And as I told you, there's still eye contact, but it's less communicative. It's less to like tell you, hey, look at that, right? When I do that, you kind of wonder, what's that on the left of Noemi that she's looking at so intently? And that 3-point gaze, or the use of gaze with a point, which is called an integrated eye gaze, is often missing in children with autism. They might focus on my mouth when I'm talking instead of looking at me in the eyes, or they might look at me with a side eye. A lot of kids with a dual diagnosis of Down syndrome and autism may be progressing a little bit more slowly with some milestones, especially things like self-feeding, learning to use the bathroom on their own, including being aware that they have to use the bathroom or communicating that they have to use the bathroom. Taking care of brushing teeth or brushing hair, and then a slower development of communication. And then I hear a lot of behavioral challenges from the parents of kids with a dual diagnosis, maybe some more impulsivity or hyperactivity, often more aggressive type behaviors like hitting or biting, and especially self-injurious behavior. Someone is hurting themselves. Always make sure I'm really evaluating if there might be a dual diagnosis, especially if it's not like some little kids will like look at straight at you and go like, to really make a point that they are mad. That's different than someone who is repeatedly banging their head without necessarily checking if someone is watching, either because they are overwhelmed or upset, or maybe because it's serving some sort of sensory purpose. And they can be more difficult to calm or soothe. And then some children might show some regression or loss of previously acquired skills. And what I always say is anytime there's a loss of skills, this requires a full medical evaluation while evaluating for autism. Are there new seizures? Is there new thyroid problems or other serious illness that is explaining the loss of skills separately from the concern for autism? So some take-home points about what autism looks like in children with Down syndrome. Parents' concerns might just be that their child is a little different from other children with Down syndrome. Signs of autism might begin to be seen a little bit later than in children without Down syndrome, maybe 3 to 5 years old, as opposed to 1.5 to 2 years old. Families may experience a harder time getting their concerns heard by providers. And the symptoms that we are looking for are symptoms of autism, knowing that a lot of the things that I have described can be also seen in children who ultimately just have Down syndrome. But when we are hearing about many symptoms in many different categories, then we really should be thinking hard about a co-occurring diagnosis of autism. And so, how do we evaluate? At this time, there is not a ton of scientific evidence around best practices for evaluation, but we are doing better. There is a lot of research that's coming out on best practices. We always start with the basics. Can the child hear and how well? Can the child see and how well? Is the thyroid okay? Is there anemia? Are there other medical conditions that explain the communication, social difficulties, repetitive behaviors, and sensory needs? Hearing loss is very common in people with Down syndrome. The child might look like they can still hear, but if their hearing is really muffled, it can make it really hard to learn to talk. A child with Down syndrome may look like they can see even if they have a really strong prescription need, but then it might look different if they're in terms of their eye contact or their ability to look at the same thing we're looking at if a plane in the sky is so far away that they can't even see it without glasses and if they don't have glasses. There are some screening tools. I want to mention one that is freely available online that is used routinely in the United States. It's called the MCHAT, Modified Checklist for Autism in Toddlers, Revised. It is free online. It's only 20 questions. It doesn't take very long to fill it out. In kids without Down syndrome, you can use it up until the age of 30 months, but in kids with Down syndrome, you can use it until the age of 5 or 6. And as kids grow older, it might actually be a little bit more helpful because some of the questions ask about whether your child talks like other children. And of course, a 2 or 3 year old with Down syndrome alone still might not be talking like other children without Down syndrome, right? But then other questions ask about the use of pointing, about sensitivity to noises, about repetitive behaviors, which are the same things that I just told you about, right? So it can be a really helpful and quick screening tools that you can use on your own and that your doctor can use as well. So that's the MCHAT, and it's a screening tool. In the United States, we use an evaluation called the ADOS, or Autism Diagnostic Observation Schedule. It takes about an hour to administer. It involves the use of lots of different toys. There's a part where we just watch a child play, and then there's a series of things that the examiner does to try and see how the child responds. One might be calling their name. One might be saying, "Hey, Noemi, look," and seeing if the child follows the pointing. At one point we take out bubbles and we blow bubbles, and then we stop and we see what the child does, and if the child has any sort of communication overture, communication attempt to get us to continue to blow the bubbles. At one time, the child is playing, and then we block their access to the toy again to see, does the child look at us to be like, "Oh, what are you doing? We were playing. Move your hand." Or do they, without looking at us, just try to move our hand away or just stand up and walk off? These are just some examples of the things that we do as a part of a longer developmental evaluation to try and tease apart whether what we're seeing is a child with Down syndrome only or a child with Down syndrome and autism. The tough part about things like the ADOS and other measures is that there is not enough scientific data about how well these tests work in people with Down syndrome. My team, along with a team at Harvard and a team in Colorado, is actually testing and studying the ADOS in young children with autism. So I really hope that I get invited again in a couple of years and I get to bring you updated information that has scientific data to tell you which parts of something like the ADOS can help us understand if there's also autism. Our general recommendations from a group of experts in Down syndrome and autism, largely based in the United States, is to use an interview of the parents using questions from autism parent interview called the ADIR to ask about symptoms of autism, much like the ones that I just described, to also connect with teachers and therapists to understand about the social interactions that they are seeing. Sometimes they come to see me in a completely new environment. They're not showing me their best skills, right? They're overwhelmed and a little worried about whether I'm going to also give them a vaccine. So it's important to know what they are doing in environments where they feel more comfortable. There are scales like the social communication questionnaire that asks specifically about communication skills and especially in the area of communication for social purposes. And then there's a tool called the Aberrant Behavior Checklist that looks specifically into behaviors that we might see: aggression, self-injury, repetitive behaviors. The Vineland is one example of a scale that looks at adaptive functioning, as we were talking about things like toileting, self-care, and then I mentioned the ADOS. So these are our current recommendations for what to use when you're assessing someone with Down syndrome to determine if autism is also present. Now we have diagnosed autism. How do we help? How do we help children with a dual diagnosis improve in the areas where they are experiencing challenges? Again, I need to name that there is limited research on treatment for Down syndrome and autism. Once again, we're working very hard in the research space to improve our knowledge. It's important for me to say that over and over, what I hear from psychologists, from doctors like me, from parents, is that the reason it's so important to know if there's also autism is that autism is the primary issue. And we need to use autism specific interventions to really help our children with Down syndrome plus autism thrive. So of course, we need to think about what are we going to intervene on. So we talked about the communication difficulties, the difficulties, this rigidity I focused less on, but big difficulties with transitions and novel situations that deviate from a routine, difficulties with social skills, behavior concerns, and self-care skills and sensory issues. And then, of course, the safety concerns that can come with behavioral challenges. These are what parents, when we surveyed them, told us were their main concerns when it came to their child with Down syndrome and autism. So these will be the primary areas of intervention when we think about intervention. And we have to start with goal setting. So I always say, where are we hoping your child will be? What are you hoping they will do? Long-term perspective, we want lots of independence, we want safety, we want really good quality of life. And then we think about goals that support those long-term that long-term vision. So we want to really help communication, we want to really help social functioning, we want really address self-care. And then we look at short-term objectives that can help us get to those long-term goals, like making sure we have shared attention, that both of us are paying attention to the same thing so that I can teach you that thing, that you learn to wait, and so that we can be in an interaction where some waiting might be involved. And then, of course, working on using communication as opposed to behavior to get a point across. Not everyone will respond to the same intervention in the same way. Some children will receive more intensive interventions and you might see progress faster. Some children may only get to receive a couple of hours of behavioral interventions a week, and maybe with providers that keep changing. And so then they might not be improving as quickly as those who are receiving really consistent intervention. Sometimes, we're working on autism interventions and then a child gets sick, and then we have to focus on taking care of them when they're sick. And so if a child is having a lot of medical issues, the progress on the autism therapies might be slower because we're also having to spend a lot of time in the hospital taking care of medical conditions. Some of our families are homeless, and it's really hard to really focus on therapies when we're more worried about where we're going to sleep at night. So again, when we think about how well these interventions work, there are some characteristics specific to the intervention, and then some of them of the child, right? Just like some of us are really good at math and some of us are really good at reading and literature, some kids with Down syndrome and autism have greater strengths in communication, and others are really challenged in communication, and same with sensory or social interaction. And so different children might respond differently to the same interventions. There are several interventions that can help a child with Down syndrome and autism. One is called Applied Behavioral Analysis, or ABA. It's a therapy that helps kids with autism and also kids without autism learn skills and lessen problematic behaviors. It uses principles of behavior therapy quite intensely to help develop these skills. This means understanding what behaviors we're trying to target, understanding what things tend to happen before that bring on the behavior, and what things happen afterwards that keep the behavior around. An example is if the behavior is dropping on the floor, screaming and crying, what comes before might be, hey, every time we go in a really loud public place, this happens. And so we might be thinking about, is there anything that we can do to modify that environment? Maybe we wear noise canceling headphones. Maybe we avoid the grocery store at the busiest time. And then the child drops on the floor and is crying and screaming. And then, of course, we pick up the kid and we leave the place. And so, what comes afterwards, getting out of there, escaping the challenging situation, made the behavior work, right? If the behavior meant, this is too much, get me out of here, and then the parent gets you out of there, then the next time I'm going to be in that situation, I know I better drop on the floor and have a big meltdown so that someone gets me out of there. And so ABA therapy might look at how to modify the environment and also might look at how to respond in the moment in a way that slowly tries to eliminate a problematic behavior. It might be that we get the child to sign the word for break or for out or for all done, and then we take them out so that we are rewarding the use of a communication tool as opposed to rewarding the behavior like dropping on the ground. This is a video that I don't have time to show you, but it's quite nice. It is available on YouTube, and so I put a QR code so that if you want to bring your phone to the screen and scan it, you can have it and you can watch it later. And it shows an example of how ABA therapy is being implemented for a child with Down syndrome and autism. There are parent trainings that can work and support parents as they're working with their children. They're based on the same principles of applied behavioral analysis. And it's the therapist that's working with the parents and teaching the parents how to work with their children. There's growing evidence of these interventions. Some of the names include Ruby, that's focused on behavior, Impact, that's focused on communication, Jasper, that's focused on play and communication. And parent training has been found to be superior to just parent education. So telling someone in course of a short visit how to work with their children is not going to be as effective as having a therapist coaching the parent more intensely. For areas where resources can be scarce, I see uh, uh, a question, for example, in the Q&A about where some of these resources might be. The availability of some of these parent coaching interventions remotely through video, and the fact that we have shown that they can work even remotely, even by video, is really encouraging, right? Because it means that we have a chance to really expand access to this support, even in areas where we don't have enough therapists, enough psychologists to work directly with each child. We want to make sure that we support communication, whether it's sign language or uh, paper-based picture communication, where a child points to the picture or hands you a picture, or higher tech communication methods like iPads with a communication device where the child presses a button and the iPad says the word for what they pressed. Um, I love sign language. I told you I talk about sign language from very early on, and I think every child with Down syndrome should have access to sign language. These other methodologies, therapists can work with a family on learning. In the United States, they can often be accessed either through insurance, through a speech therapist, or through the school. Speaking of school, it is important for school to be very structured. And so a child with Down syndrome and autism may need a lot of support of the physical structure around their learning to minimize distractions, with a clear schedule of what happens first, then, and then, with a chance to feel good about completing a task, and with lots of breaks that are scheduled between each task, and with rewards for completing each part of a task, and lots of routine and lots of visuals. I always say visual is king in Down syndrome, and visual is king and emperor in Down syndrome and autism, because it is just so important to present things visually. Just talking to someone with Down syndrome and autism may not be enough, because the auditory processing can be a little more challenging for those with Down syndrome and autism. Um, some children with Down syndrome and autism also need medication to address focus, to address behavioral challenges, to address anxiety. Um, there's different medications that can be used. Uh, Big principles I talk about are: one, we have to have clear goals of what the medication is for. If the medication is for decreasing the amount of self-injury, we might not expect that it will also help with focus. So I will not be disappointed if it's not necessarily helping the child focus better. I will be very happy if it's helping with the self-injury, right? So I'm going to judge the effectiveness of the medication by tracking very clearly the goals that I set for that medication. And the big message is that we start at lower doses than where we would otherwise be starting for a child without Down syndrome, and increase very slowly. And there is no medication that quote unquote cures autism or takes away autism, but it can decrease symptoms in various areas, including aggression, hyperactivity, irritability, self-injury, anxiety. And this table shows examples of some of the medications that we use to help children with Down syndrome and autism. So as a take home to help children with Down syndrome and autism, applied behavioral analysis can be quite helpful. Parent training can be quite helpful. School can be very helpful, especially if it's highly structured and supported. We want to really offer communication support. One piece I didn't spend as much time talking about is the sensory piece. A lot of my patients with Down syndrome and autism work with an occupational therapist to support their sensory needs. If you have a Down syndrome clinic near you, an expert in Down syndrome like me can be quite helpful in diagnosing and referring to appropriate therapies. And then consider medication, especially when specific behavioral symptoms are quite challenging. And what about the family? I hear from a lot of doctors, what's the point of diagnosing autism? Don't they have enough with the diagnosis of Down syndrome? What would it even change? And I have to say that, you know, often when I give a diagnosis, there is a period of, oh my goodness, another thing. And a lot of parents actually feel relieved too, because they knew that there was something different and because they thought that it was their fault. They thought that it was because they weren't working hard enough with their children. And instead, it was because there was this whole other big thing, autism, that hadn't been diagnosed, supported, addressed. And once we start working with autism specific therapies, all of a sudden we see improvement. And that's the take home message is that kids with Down syndrome and autism can do quite well. They can really learn a lot of skills and learn a lot of skills of independence and skills of communication. And the communication might look different. For some, it will be a lot of speaking. For many others, it might not be a lot of speaking, but it can be a lot of signing and using these other communication modalities. But communication it is. And so we can really help kids with Down syndrome and autism, and we have to use autism specific interventions. And so there are recommendations for caregivers of Down syndrome and autism that include advocating for your child, speaking up if you think that there's something different about your child, familiarizing yourself with assessment modalities, and then knowing that there are available resources and supports that can help you and your child. There is an online support group that is freely available to join. It's called the Down Syndrome Autism Connection, and you can access them through their website and on Facebook. There are books that you can read. There is a second edition of this book, Down Syndrome and When Down Syndrome and Autism Intersect. And if the first edition was good, the second edition is amazing. And every person who's doing work in the space of Down syndrome and autism collaborated to write a chapter in this book. So I strongly recommend it. A new course, A Mother's Journey Navigating Down Syndrome and Autism, is another fabulous resource. This is the lived experience from a parent. And then there's Down syndrome and autism specific organizations that also have resources to learn more. I want to acknowledge the Down Syndrome Medical Interest Group. That's my professional organization that is doing a ton of work in this space. And I want to stop here and be able to answer questions in the time that we have remaining. Thank you for your time.
Naomi,
Yes,
it was very fantastic.
thank you.
Um, I see that we had some comment question, but that was mostly fully answers. We have one from Italy, Marco
Yes,
Gidali.
yes,
Do you
yes,
see it's a question? I don't know. Do you
yes.
know anything about this?
Yes, so the question says, in the north of Italy, are there competence structures for the evaluation of the co-occurrence of autism in a child with Down syndrome? I'm not as familiar with what is available in Italy, but I do know that in Italy there is a strong Down syndrome organization that can help you can help direct you to Down syndrome clinics throughout the north of Italy. I believe there are a couple. I think one maybe in Florence and one in, I think there might be one in Lombardia. I'm not quite sure though. Though I am Italian, I have not lived there for over 20 years and I practice in the United States. Dr. Diletta Valentini runs the Down syndrome program in Rome, and she can also be a fabulous resource.
Yeah. Okay. Thank you very much, Naomi. We have also hands of Jacqueline London. Please, Jacqueline, you have a question for Naomi?
Yes. Do you have by chance found any kind of person with partial trisomy 21 or mosaicism having also autism? That is my first question. And the other question is, what do you know, or is there any knowledge about genes which are involved in competence intelligence, DOC1A and ADPN?
Okay. So the first question, do I know of any children with mosaicism who also have autism? Of course, about 1% of children, of individuals with Down syndrome have mosaicism. So it's a very small minority of children. In my practice, I have three patients who are mosaic. So no, in my practice, I do not have children have mosaicism and are dually diagnosed. I do not know if there are people out there with mosaicism and also autism. It's a good question. The studies that we are doing always ask about the genetic type of Down syndrome, so hopefully we will have more information. And there are ongoing studies that are looking at genomics in kids with Down syndrome and kids with Down syndrome and autism to see if there are particular genes that can predict a co-occurring diagnosis. So we don't know yet, but we are looking into it. I'm going to start reading some of the questions in the Q&A and answering them for the sake of time.
Yeah. Thank you,
Pia,
Naomi.
Pia asked, is it common that kids with dual diagnosis have big sleep problems and any tips on that? Yes. Oh my goodness, yes. And so first of all, a lot of people with Down syndrome have sleep apnea. And while and it's important to know that the sleep apnea can be quite tricky to diagnose because children might not be snoring. You might not be hearing obvious pauses in their breathing, and yet there might be sleep apnea. So it's very important for all children with sleep problems and all children with Down syndrome in general to get a sleep study. Sleep difficulties are actually very common in people with autism in general. Trouble falling asleep, trouble staying asleep, waking up too early in the morning. And this is very common in people with autism, including in people with Down syndrome and autism. There are some behavioral things that you can do to help, including really strong bedtime routines, making sure that the timing of food and screens and play are such that they're not too close to bedtime, that we absolutely no screens near bedtime, please. And then other sensory things that can be done to help a child fall asleep. A lot of children with Down syndrome and autism end up needing to take either melatonin or some other medication to help them with sleep if there are sleep concerns. And I always say, think about medical issues first. Is there sleep apnea? Is there reflux? Is there constipation? Is there pain that's making it hard to sleep? Someone asked me where I am in California. I am in Oakland, California. How would I diagnose a child who's 19 years old? Depending on their presentation, I might give them a clinical diagnosis if it's obvious, and if not, I would refer them through their insurance because I would only have until they're 21 really to get their autism evaluation covered. So I would really advocate for a prompt referral through insurance for a diagnostic evaluation. Thank you for the compliment on a good presentation. And Luana Intile answered the question from Marco Guidali, letting him know that at Bambin Gesù in Rome, they have developed, there is the availability to have a neuropsychiatric evaluation. That's a program I was mentioning that is run by Dr. Diletta Valentini. That's, I believe, the largest Down syndrome program in Italy. Would I recommend TNI nutrition at double diagnosis? There is no evidence behind TNI. TNI is an abbreviation for a series of nutritional supplements that are often recommended by supplement companies for people with Down syndrome and autism. They make very big claims on their websites that it cures everything, and they have zero real evidence to support it. What I do in my practice, I make sure that my children have good vitamin D levels, good iron stores and iron levels, which can also impact sleep. Iron is very important for the brain. And then I make sure that they have a good, healthy diet that includes fruits and vegetables that provide the vitamins and micronutrients that children need, good amounts of protein, and overall a varied diet. And I told you that feeding difficulties are very common in children with Down syndrome and autism. So sometimes this does mean adding a multivitamin if their diet is very restrictive, right? And working with a feeding therapist to help them expand their dietary repertoire. So there is an eye to nutrition and nutritional deficiencies for sure. And that's different from the very expensive nutritional supplement regimens that some specific companies present as the cure to everything without any real research behind it. And I warn parents that there is no evidence, and then I still encourage them to tell me if they choose to pursue it, because I want to make sure that we're not overdosing on any one vitamin. I actually have several patients who are on some sort of vitamin regimen who actually ended up having levels too high of vitamin A, vitamin E, and vitamin Bs. So I want to know if you're taking these supplements so that I can monitor them with you, but I don't usually recommend them because there's no good evidence behind them.
Noemi, this is in German. What does the abbreviation ADLS mean?
ADLs, activities of daily living. Thank you. I'm so sorry for having abbreviations in my presentation. Activities of daily living, eating by ourselves, grooming ourselves, using the toilet by ourselves, doing chores, getting dressed as independently as possible. Those are all examples of activities of daily living. Thank you for translating. And then there's another question around whether I recommend polyadenine, which I imagine is another supplement. I have not heard much about polyadenine. I have not seen research articles specific to their effectiveness. I have an alert every day on my phone of every article that is published that has the word Down syndrome in it. So I consider myself pretty up to date on the research. So this is not something I routinely recommend. I recognize that there isn't a lot of research in these areas too. And so again, I'll do the reading with you if you're my patient, and we can look into it. And above all, we will make sure that it's not interacting with medications that you might be taking, and that it is not putting you at risk for toxicity. How do I deal with children who panic at seeing any kinds of doctors? I have done visits in the hallway. I have done visits in the parking lot. I do a lot of video visits too, because sometimes it is easier to hear about concerns from parents and then be able to see the child afterwards for a shorter visit to help me with the evaluation. You can only see my top half, and I worked really hard to look nice for you today, but I'm always wearing yoga pants underneath because I do my visits on the floor and I never wear a white coat. And I have lots of toys and I don't wear my stethoscope. And if a child feels really worried and scared, then I make sure that it doesn't feel like a doctor visit at all. And if I really do need a height or a weight, maybe I do it at the back end after I have finished. Some children do need a little bit of medicine to help them with their big anxiety before a doctor's visit and especially before a blood draw. And it does help to really prepare a child with visuals for what might happen during a visit, because if they are prepared, then they might be less anxious. And I know that we are out of time, but I do very briefly want to share my screen one last time just to show you that we have a website. It's called Charlie's Clinic at .org, and we have a section on autism. And in this section, there are a lot of information. There's a lot of information about the dual diagnosis, some recorded talks, not too different from this one, and resources for learning. But there are links to some of these sorry, it's taking a while to load. There's information about ABA, but there are some links to other parts of the website where we guide you on other helpful resources, including sensory support. So for example, here, there's information on behavior and there's social stories, including social stories for getting ready for procedures like going to the dentist, going for a sleep study, going for a blood draw. And I give families these resources if I see that a child is feeling really anxious so that they have materials to help prepare their children. In the United States, we have TV programs like Daniel Tiger and Miss Rachel and Sesame Street, and they all have short cartoon episodes that talk about going to the doctor, going to the dentist. And I tell parents that that's their homework before coming to see me, is to watch those shows with their children every day for a few days so that it doesn't feel like something so scary.
At the moment, we don't see some new Q&A. Noemi, really, you told us so many things. I think all of us, we need to listen you again, because it's a lot of very interesting things what we could share with our families and also with our children, youngsters, even with elders. Some suggestion, because after some time we forget some things, and it's good always to repeat and start to think and follow some activities what you also say to us. If there are no any more questions from audio here and also from the Q&A, really thank you very much what you put your website. I hope everybody could see this. This is a address of the your
They can't see
website.
it, but I will answer to Stuart with the link to the website too. So
Okay.
if you go in the Q&A,
Yeah. We'll have it.
it is here.
Yes,
Can
please.
you have my email address? I I cannot answer every email from every person. I take care of so many kids and I do so much. Um, I am sure that if there are very specific questions, EDSA can send it to me and I can try my best. But and you know, if you really need my email, it's in many places online. But I just want to be honest that I cannot answer lots and lots of questions from parents all around the world at this time. I wish I could, but I need a cloning machine.
Yes, yes, yeah. We know how that is, but your email address is near your picture, what I could see on
Oh,
my screen.
there you go. Busted. Yeah,
Naomi, thanks a lot. Thanks to all who participate today on
pleasure.
our webinar. For you, have a nice day. And for us in Europe, we are in the evening.